Hi, everybody. I'm Raj Kumar, President Editor-in-Chief of Devex, coming to you once again from my kitchen here in Washington, D.C., bringing you as much as I can interesting conversations with leaders who are right at the forefront of this. And boy, I'm really excited to have my friend, Dr. Githinji Gitahi here. We see each other normally, Githinji, on panels and stages all over the world on kind of the International Global Health and Development Conference circuit. But this is the new reality. So thank you for taking some time from, you're in Nairobi, I assume now.
I'm actually, I hear you in your kitchen. I'm in my dining, so.
Okay. Well, thank you for taking some time from Nairobi in your dining room to have this conversation that we're trying to bring out to people in the Devex community on what's really going on around the COVID-19 response. You are, of course, the CEO, worldwide CEO of Amref Health Africa, a leading international NGO working across all of Africa. You're a big outspoken voice on all things health and development. You're a co-chair of UHC 2030. You're on the board of the African CDC, medical doctor by training with a business background. You are very active in the Kenyan media. So lots of things I want to get your take on, but maybe before we dive into anything specific, just overall, how do you see things going? What's your kind of general assessment about the situation that we're in?
Well, I think the situation has been anxious, is what I would like to say, and guarded because we do not have enough evidence in terms of how this is going to move, especially because, as you know, a few weeks ago, we had people saying, Africa is safe, Africa will not get corona, it's not going to be a big deal. So, we had conversations and rumors and myths about temperature, about the African gene composition and all these things. So I think we have seen that, Africa is not going to be spared. We think that it was largely travel density that was an issue, but we don't know how this is going to span. We don't know how high the peaks are going to be. We don't know what our mortality rates are going to be, or the rates of severe and moderate disease. We have a different demographic from the rest of the world. So we don't know how it's
a lot younger, right? A lot of younger people, but then also a lot of underlying health conditions. You got, high HIV/AIDS population. So it's hard to see how that might all play out.
Exactly. So we don't know, but we know that we are preparing for the worst because, as always, for COVID-19, you're always a few steps behind where you think you are. So
I saw you in the Kenyan media advocating for people to really kind of hibernate, to stay home, really pushing that message. Is it working where you are in Nairobi? Are people starting to take this seriously in the way that we maybe belatedly are doing here in the West?
You see, if you look at our socioeconomic architecture, you will see that about 80% of people are in the informal sector. So they are mainly in agriculture. They are in, day-to-day construction work and all these kinds of things. So for the 20% who are more in the formal sector, there's better response. You're seeing companies actually working to make sure that people work from home. I have been working from home for the last, maybe 2 weeks or so, and so are our staff, and we have made those provisions. But when you now go to the informal sector, the people work to eat, they work to earn to eat every day. And therefore, when you ask for people to work from home, if I'm a mason on a construction site, I can't work from home, I have to go to work. And you stop me from going to my masonry work, then I'm hungry and you have to provide for that. So we are seeing that even though people may have the willingness to actually observe staying home, it's not possible for them. And that's what we are experiencing. But also there's a lot of cynicism, I must say. Cynicism, and because of the fact that, coronavirus doesn't have a face, really. It's like chasing a ghost. It doesn't have a face. When you talk about other diseases like cancer, you can show people how cancer looks. You can show them, but coronavirus doesn't have a face. And therefore, majority of our community people who are not really highly exposed are still doubting, really, is this thing existing? What is this going on? Is this probably just a development agenda and therefore money is changing hands and this kind of thing? But we are starting to see also people responding. Today I got photos from across Kenya of households that are placing water and soap at their door and saying, if you're coming to visit, please wash your hands. So the message is getting home. It's just going to take time, and it's going to take a different path from the way it has taken in Europe and North America.
Yeah, let's dig into that a little bit more. I was actually in Nairobi and visited Kibera maybe just a few months ago. And I'm trying to envision what you just described, which is, a community of people who are very tightly packed, who have to leave their home to work, to get food, right? Even just to go to the market. If they have a little spending money, they still need to go buy it somewhere. They don't have the kind of delivery services in a lot of those communities that you might have in some more upscale communities in Nairobi, I would imagine. So how do you think this begins to play out? I've talked to a number of leaders and people working global health in Africa who say, look, our health systems were already stretched. And people who had respiratory illness already didn't have access to the best technology or the necessary intensive care services. So how do you think this might actually begin to play out there as we see the numbers spike? Right now, most of the cases are in Northern Africa and South Africa, but at least that's based on the testing that we have so far. So give us a sense, I think in the media you said 4 to 5 months, before you see a peak, or give us a sense how you see it sort of playing out a little further.
So we have, Raj, we have modelings and projections of how this is likely to go using whatever we see, the incidence and infection rates that we've seen from elsewhere. And what we know now and what we see now is that a country like Kenya with 47 million people is likely to have 10,000 positive cases by mid-May, okay? Now, that you can then reflect that across many of the African countries. So basically we are saying that in the span of a few weeks, probably 5-6 weeks, each of the countries are going to be seeing thousands and thousands of positive cases. The question is...
Can I just interrupt to say, in some ways, that number sounds very low for a country as big as Kenya, given how transmissible this virus is. Is that based on maybe faulty numbers that we have today because the testing is not there at this point? Or give us a sense, I don't mean to interrupt you, but I just want to understand better how you're coming to those figures.
No, the 10,000 doesn't mean that that's going to be the peak. It just means that if you look at many of the countries and the progressions, geometric. So you say, many countries are taking up to about 30, 31, 35 days to start seeing the geometric peak. So if you look at Kenya now, we are on day 20 actually. So we're saying that by the time we get to day 35, which is just 2 weeks down the road, we start to see the geometric progression go up. So we are saying that by mid-May, the geometric progression will probably give us about 10,000 cases. But that's not the maximum, that's not the peak. It's just in terms of short-term and medium-term planning. Those are the numbers we are looking at. We might be getting into 150,000, a few more weeks down the road. But we are saying if you have to look at just what we are facing in a few months, in a few weeks of quick response, we are saying when you have 10,000, 20,000 cases in a country like Kenya, then you have to start to think around, number one is, you have to start to think about how do you prevent transmission. You have to then start to think about how to ramp up your testing capacity. Remember that testing capacity, Raj, is not purely getting test kits. It's also about the environment in which you're testing. It's about contact tracing. It's about finding the suspects. It's about going to those informal areas and tracing people where there are no addresses. There are no physical addresses for the houses. It's about, therefore, just kind of a lot of intensive and labor-intensive work. But then, even after that, what do you do when you find the suspects? You have to, there's a process of collecting the sample. There's a process that when you're collecting the sample, the health worker needs to be kitted to protect them. So there is availability of personal protective equipment. And then you have to transport the sample because it's a virus. It could die on the way. So you have to transport the virus in what we call virus transport medium. So all these other factors are the ones that are limiting the testing capacity. It's not purely the test kit. So even as you look at that, then you say you have now 10,000, 20,000, 30,000, means your capacity to test is going to be extremely, extremely stretched. So we are happy to see that research is bringing more and more rapid testing ability of what we are using. But then the next question is, when you test these people, where do you take them? You know, in organized society, you can say we have areas where we are going to isolate people. In fact, Italy, they were attempting to do home isolation. Of course, we saw a problem with that. We started seeing a lot of home clusters. But in even more informal sectors like Africa, you have to get the people out of that community and isolate them. So we are talking about creating spaces to isolate over tens of thousands of people. And that capacity has to be built in a way that's makeshift. Maybe you're going to use university, school spaces, hospital spaces, churches, whatever it is that we are going to use. We have to think about that in the next 6 weeks. You know, it's not
and those are conversations that you and the government and other leaders, you're engaged in those right now, thinking about where to put people whom have the infection and need somewhere to be isolated from family and community.
Exactly, and remember that the government doesn't want to build infrastructure which they won't have use for after that. So you have to think about existing infrastructure and how to repurpose it to be isolation centers. So those are things we're thinking about.
There's a lot that has to happen quickly. And one of the potential advantages that you see in places like Kenya and much of sub-Saharan Africa is the community health worker cadre. That you have some more experience there with actually contact tracing and surveillance for other diseases, but that can be used in this way. What are you doing at Amref? What are you seeing in terms of leveraging existing systems and trying to repurpose them for COVID-19?
So in terms of, there are several areas here, Raj. One area is the area of community awareness and community engagement, because at the end of the day, if you don't engage the communities, if they're not core, whatever things you put down is going to be a problem. Because of course, as we say, there's always a trust barrier between the community and the government. And even when you start to do physical distancing and social distancing, you want it to succeed by the people's own will. You don't want it to succeed through the baton or the police. And for you to do that, you need to engage community health workers, talk to the communities and explain to them. So we are using them, the first thing, to educate them, tell them what this is and what they can talk to the communities to do. So that's the first base. And we have a curriculum in Kenya. We are now training about 60,000 of them in the communities on the basics of COVID-19 prevention and what they need to do. Now, the next step is to move into now using them for contact tracing. That hasn't started yet because the cases are low. So the medical professionals, the rapid response teams are still able to manage. But now we are moving into that space of preparedness that we know we are going to have 10,000, 20,000, 30,000. And it's not enough for skilled health workers to be only the ones that are tracing, that we need community health workers to trace. Then you have to think about their protection, and you have to think about the protocols that are required for them to be able to trace a highly infectious disease. So that's where we're getting into now. But we've already started training, and we are working with the government, we are working with Africa CDC to see how we can ramp up that activity across many of the African countries.
Let's go a little further on
also, that. Because we are using, because a lot of the, of this also requires that you maintain physical distance. A lot of what we are using now is technology. We're using mobile phone to train them so that we can reach them without having to ask them to come into a meeting.
And the advantage we have in some ways is some of those systems have been built in the intervening years for other disease areas. So hopefully we can build on that. But let's dig a little deeper if we can on this idea of personal protective equipment, PPE. There's shortages, it seems, all over the world, including here in the United States. CHWs, there are large numbers of them. We were talking with Raj Punjabi of Last Mile Health, who was concerned that even the WHO estimates may not include CHWs for having PPE. Have you decided yet at Amref, is there a conversation in Kenya or in East Africa more broadly about what is the minimum PPE requirement for a CHW? How do you see this going forward? Are you currently on the phone with vendors? Are you talking to warehouses to try to find this kind of equipment? Give us a sense of what's happening on the PPE front.
So there's a major shortage crisis for PPEs, and I think it's global. And locally, when we are seeing that because of the closure of borders, even where you may be able to negotiate PPEs, there is kind of a barrier to the supply chain. So that's a big problem. And the other problem I see, other than manufacturing and supply chain shortages, is usage protocol. Now, what's going on is because of the anxiety that is surrounding COVID-19, you find that the health workers, even when they're doing condition or the tasks that don't require full kitting PPE, they insist on a full kitting PPE because the protocols, they feel I am more protected. If you're sending me to the field to suspect, give me a full kit PPE. I can tell you that a full kit PPE in Kenya, in Africa, is costing $100. $100. So you can imagine that. And
this is just so people know, this is the N95 mask, the gown, the face shield, right? The whole kit.
So it is the suit with the hood. It is the goggles, those are recyclable, but the hood is not. It is the gloves that you need, that some of them may have, maybe have nitrate oxide inside to kill germs. It is the boots. So when you look at this whole thing, it's close to $100. In fact, the last search we were doing, some people had inflated this to $250 per kit. And you remember that a lot of this is single use. So even from a resource point of view, it's a major issue. So we've been talking with the government and WHO about the protocol for use of PPE, and WHO has now released some guidelines to say who should use what form of PPE. And we are now able to say that actually, if you're doing contact tracing and you are in a place where you don't have high contact, you can just use the mask and gloves, and maybe goggles if you think you'll be coming into contact. But mask and gloves could be adequate for the initial non-high contact areas. So those are evolving. Those are evolving conversations. Remember, this is just 3-4 months of dealing with this. So studies are coming up about aerosol transmission. We don't know. We are seeing conflicting studies as well. So for now, we know you can work with masks and gloves for at least community tracing. But when you have to do patient contact, then you have to increase the level of protective equipment.
Are you aware of any conversations around manufacturing locally? Are people starting to locally manufacture masks or face shields or gloves or any of the other PPE equipment in Kenya or elsewhere in the region? It seems like that might be a key element of this. Right now, a lot of our hopes are sort of pinned on everything being flown in from China. Jack Ma gave a famous large-scale donation of this equipment to Africa. But what do you know about those discussions about local manufacturing?
So the discussions are happening. They are happening at a local level. They are happening at a continental level as well. So I'll let you know that the Africa Union has been discussing this, and there was, I am aware of those conversations, and they're looking at this at 3 levels. One is, how do they prevent transmission? Secondly, how do they prevent death? And thirdly, how do they prevent social harm? That's the social and economic aspect of this. And within this, they have said we have to have a continental approach, and that continental approach will require us to manufacture some of these items. We manufacture where it's possible, and then we have a joint supply chain so that we can distribute country to country instead of every country struggling on its own. Africa has 1 billion people, but they're spread out into 54 different geographies. So the manufacturing conversations are going. One of the areas that we know we can do is, basic masks, surgical masks that are already being ramped up. Secondly, the protective suits. Thirdly, the gumboots. Fourth, the gloves. But areas like N95 masks, which are high end, will take us longer to say that we are going to do local production. Because also you're worried about you must assure yourself of the quality, because you don't put health workers at risk. And we have seen that in some of the countries where health workers have actually had to carry the burden of this. Many of them infected and several of them dead. And we don't want that. So we have to be very careful about the quality of production.
We've had, of course, in different parts of Africa, we've had the Ebola crisis in West Africa 5-6 years ago. We had, the Ebola situation in DRC. How do you assess COVID-19? Is it kind of the big one? I mean, is this a much bigger deal for Africa than those crises? Is it relatively minor? It's going to be several months of social distancing, but it's going to pass through. How big of an issue is this for the continent in your assessment at this point?
Raj, this is big in its magnitude. This is likely, from a general point of view, and I'm no economist, I think I would fear that this can reduce Africa's GDP by 30-40%, in value.
I was surprised to see, McKinsey came out with their estimate. They're saying it's a 3 to 8% drop in GDP in 2020, and it sounds, awfully low to me. But it's interesting to hear your take.
I'm not an economist, so maybe they have more economists than me. But looking at what's going on right now, and just looking outside my window in Kenya, restaurants have closed. All the hotels have closed. There's no Easter going to happen. There are a lot of local tourism, domestic tourism. All that is gone in these few months. My estimate in the tweet I did, which actually went viral, was saying that people should not see this as a short-term thing. I was seeing the effects of the public health measures will be minimum 4 to 5 months, because if we are talking about the peaks coming in May and June, the governments are going to just get tighter and tighter. They're not going to get relaxing the measures. So you're saying that businesses are going to go down significantly. I am board member in a few of the corporations in Kenya. And I know I was just looking at one of them. I chair some of the committees, and the business between February and March has already gone down by 40%, you see, and this is just the beginning. So to say it's going to be 5-8%, for me, I don't believe that, and I'm happy for McKinsey economists to prove me wrong. It's going to be significant. People have lost jobs, restaurants have closed, schools have closed, colleges have closed. That is going to be massive. So it's massive. Number two is that from a public health point of view, we haven't seen this kind of social disruption in a long time. Because when you look at Ebola, Ebola was something that you could actually identify the infectious patients and put them away. Here, it's what has been described as chasing a ghost, where actually you don't know where the virus is. And therefore, when you think you're ahead, you're behind. So therefore, you have to keep increasing the measures. We have seen Uganda close down public transport, even private transport. We've seen now South Africa do a lockdown. We are seeing countries like Kenya in the face of lockdowns. So it's going to be significant, nothing that we have seen before. And both the public health, the health system, and the socioeconomic effects are going to be long-term and significant.
Well, in particular, you talk about the African Union and their 3 pillars, and that last one on social harm. You know, it reminds me of the Ebola crisis, where more people died from secondary effects, not from Ebola itself, but they had malaria and couldn't get treated, right? Or a mother giving birth who couldn't get access to health care. And in this case, what's very worrying about what you're talking about with massive decreases in economic output and social disruption, all of the informal workers who are living on a thread, you know, they don't have savings to rely on. How do you think that might play out for the many other development and health issues that you at Amref and others in the Devex community are working on? What would you say as you're talking to leaders of other kinds of NGOs, other international agencies who might not be working specifically on COVID-19, but on what this is going to mean for just development work in general in Africa going forward?
You know, one of the things we need to remember is that generally we are saying that this is likely to overwhelm the health system. And we are saying flatten the curve so that you don't overwhelm the health system. Now, in the context of what we've just spoken about and protecting social harm, if you have 80% of your people as informal, who are losing jobs, who work every day to earn a living, and you're doing lockdown, so the construction is not going on, civil works are not going on, all these things are not going on, and then you're having to think about economic rescue or feeding families, it is massive. So because of the inability of the African government to have enough resources to do that, it is likely they're going to be shy to do lockdowns, which means that it's going to be more difficult to flatten the curve. We have to realize that it's going to be very difficult to flatten the curve. Many of the African governments, Raj, remember, are now facing their first debt repayment cycles. With you know, they have been increasing debt. The debts are coming due now, so they have to pay these debts, and yet they have to look at this response. So economic rescue, they will not be possible. Therefore, they will be shy to do lockdowns because of civil unrest. Because you tell people lockdown, but you can't provide them food, you are facing civil unrest. Remember, Africa has very unstable economic environment, political institutions. So we are therefore going to see a much higher peak. That peak is going to affect the health system significantly. We have already seen notices of ministers of health telling institutions to stop elective surgeries. You know, please do not perform elective surgeries as you prepare for the peak. So already the people who require elective surgery will have to wait. And now what does that do to the health system when finally this is over and they have to come back, okay? So we start to think about those things. So the other thing is around when you have these social effects where people are losing jobs, because people are losing jobs anyway, with or without a lockdown. And many of the people in the urban centers are young people who are making a living and supporting elderly folk up country. Now, when they lose their jobs, they therefore can't afford to pay the rent. Remember that mortgage rates in Africa are very, very, very low. So home ownership is extremely low in the urban center. So where do
you don't mean the percentage that you pay, you mean that very few people can access a mortgage.
Can access the mortgage. So people who live in the cities are almost predominantly renting. They don't own the houses they live in. So if you lose your job, it means you can no longer stay in the house. You can't afford to pay. Therefore, what do? You move back up country, because up country, your family owns a house around your small farm. Now, what does that do? Most of the elderly people are up country. So it then creates an urban-rural migration, which is going to transfer the virus to the elderly people. And then we are going to start seeing elderly people getting it. And then we have a hit on moderate and severe disease. So these are things that we really have to think about. So there will be health sector disruption, and this is when the governments really need to start thinking about, even post this pandemic, what investment we require to do on universal health coverage so that we can improve the capacity of our health system, and therefore we can be able to be resilient enough for the next pandemic. So it's going to be, these are the things that we are thinking about, these are things government is thinking about, and the things we need to do.
You know, I had a conversation like this with Mark Dybul a couple of days ago, of course, the former head of PEPFAR and the Global Fund. And he's saying, why aren't we talking about investing a large sum right now? And the back of the envelope figure he gave was $30 billion into primary health systems in Africa. Why can't we take that UHC objective, understand that COVID is going to hit some of the lowest resource countries in the world, and then come back to the US and to Europe because of those reservoirs of disease? You know, why can't we go big and go bold now? And I guess my question to you is, are you hearing those discussions? You co-chair UHC 2030, you're on the board of the African CDC. Have we yet gotten to the point where we're starting to have big discussions, big ideas about what to do here? I'm not hearing it here in Washington, D.C. where I sit, but I'm curious if you're hearing that in the conversations you're in.
No, we are not hearing. We are not hearing that. I think, of course, everyone is responsible now. Everyone is in emergency mode, but we are not hearing conversations around long-term health system strengthening. In fact, within UHC 2030, the last conversation we had and the last statement we released is around this issue, saying that if we don't build UHC, then we'll never have strong enough systems for everyone. And we have done that, and that statement is available, and we can share with you. And it's basically calling for a holistic approach to the pandemic. Right now, many of the challenges we are having, as you're saying, is a weak primary healthcare system. And the primary healthcare system that is good has three legs. It has the first leg is the ability to have multi-sectoral approach. If you look at COVID-19, it is multi-sectoral. You're thinking about agriculture, food security, you're thinking about ability to trace, you're thinking about how do you rescue people, you're thinking about education, you're thinking about all these areas. The next thing is community engagement and community participation, which is extremely important. We've seen some countries that have put in curfew where citizens have come up and say, we don't agree with your curfew, we'll not implement it. And therefore you end up in a situation where it is the government again is the community. And the third leg of primary healthcare is the ability to care, to provide primary care. Now, those three areas, if they are built, we would actually see a much better response because you have a stronger primary care system, you have a responsive community that helps you to reduce, to flatten the curve, and you have private sector and others coming in because they're all integrated into a common primary healthcare infrastructure or architecture. So this is a conversation we must have, and we can't have it if we do not discuss universal health coverage and its financing and financial protection. So I would say there is only one way out of this. Long term is the way to think. Short term, we have to respond, but we have to think long term for the next pandemic.
Yeah, and as you say, even this pandemic is going to have a long trajectory. I think in some of your media interviews in Kenya, you talked about 18 months, 4 to 5 months of maybe significant social distancing and peaking of cases, but the impacts are going to be felt for a long, long time. Yeah. So this is with us. This is with us for quite a while.
It is going to be with us for a long time. What we've seen now is that some governments are increasing health workers, which is a good thing. Because if they do that for this pandemic and we then manage to sustain, then it means that we have actually improved our health system capacity over time. So there are going to be positive, consequences out of this. And those are the ones we should look at long term. When we look at ICU capacity, we should not just look at how many ventilators we have. We must also ask ourselves how many critical care nurses do we have. We must also ask ourselves how we are able to take care of people at their primary, near where they work and near where they live. So these are things that we have to think about, right?
Yeah, and I think a lot of the conversation that's being had today, because the focus is on the Western world, is quite different. There are some similarities, PPE, for example, but we don't have the same kind of health workforce system. In the West, you might say there are enough beds that can be repurposed to this. They just need the ventilators. But the situation, as you described there, where primary health care is itself weak, there's much more that needs to be done. And there's big opportunities to do it too. Maybe the pandemic becomes a reason that wakes everyone up that this is one global health system and we are only as strong as the weakest part of it.
Exactly. And I think, the question you asked earlier about, so how are we going to move forward on this? Because we need the resources to do it. Right now, we see the big danger we are seeing is that, and we have actually, you saw the Prime Minister of Ethiopia making a request to the G20 for investing in the risk response and also investing in health in Africa. UAT 2030, we're also making the same call to the G20 to say we need to look at this holistically, because even if the West or the North, the global North manages to manage this, you cannot reopen your borders until you have sorted out, in Africa as well. So it is global solidarity, and I think this is the time when multilateralism should be increasing rather than reducing. This has shown us that multilateralism is actually the route to global health security, and UHC is not something that if you achieve as a country you should be happy. Only you must also make sure that every person has universal health coverage, because then you can assure global health security. To follow Tedros, there are two sides of the same coin.
Let's go into this question of border closings a bit, because I want you to put your hat on as the CEO of a major international NGO. What is it going to be like to run an international NGO where you have staff across, I don't know how many countries across Africa and other parts of the world? You can't get on a plane, and you might not have travel between many of these countries for a very extended period of time. It's hard to say, but a lot will depend on how the outbreak proceeds and what governments decide to do. So what is it going to be like to run an international NGO going forward?
Right, this is a really interesting question, because this is what I've been grappling with. And it's, I refer to your book again. This is going to be serious disruption of this sector. And the disruptions are going to come in many ways. Number one is that, remember, the financing model for NGOs is recovery of overheads from grants that they are given by donors. And when they recover the overheads, they recover only as they burn the cash. So if you have $1 million to do a program and you have an allowed 20% indirect cost agreement, or what is overhead that's given to you, you have to spend $1 million to recover the 19%. Now, what this is going to do is that it's going to reduce this, the rate of implementation of programs. You can't travel, so you can't do trainings. We have had to reschedule a lot of the global conferences, so you're not spending. So you cannot recover the money. And therefore, even in terms of maintaining a structure, an overhead structure, is going to be very difficult. So we are going to see NGOs struggling to keep alive. That's number one. Number two is that whereas a private sector company or a multinational or corporation can make a decision to cut costs by cutting staff salaries. We've seen companies do haircuts, salary cuts, 20%, 30% to save costs. In an NGO, you are hard put to do that, because when you cut, you're also cutting from staff who are paid for by the donors. And therefore, will the donors allow you to repurpose that money for your sustainability, or will they insist the money remains in program? So you're handcuffed in terms of your cost-cutting measures as an NGO. And this is significant because it means, therefore, most of your revenue sources, you have no control over in terms of how to do cost-cutting measures, whereas in the corporations, they have full control. Now, the final thing is around creating partnerships. So you can't travel. So I can't travel to meet donors. I can't travel to share our story. That affects our fundraising revenue as well. And even the places where we fundraise are now facing crisis in their own countries. Our staff are having to work from home, so they can no longer go out to do donor acquisition, for example. So the entire model in the NGO sector is being challenged, and is going to be challenged for the next 18 months. So are we going to merge with new models? Maybe the enterprises are going to be stronger. Maybe we have to now think about how to do more enterprises that are more domestically driven, even as we look at donor money as catalytic. These are the things that we have to think about, and it's going to change the sector, and I'll be happy to continue having these conversations with my peers.
Yeah, one of the things one of your peers told me recently is that they're seeing the potential for many more mergers and acquisitions in the NGO sector now because of this weakness, where some of the bigger, stronger players that might have more of an individual donor base, might have more of an endowment or money in the bank, basically, the ability to get financing from banks, they could become the acquirer of smaller, mid-sized NGOs that will be very disrupted by this, won't be able to make payroll, et cetera. What's your feeling about that? Are you hearing similar discussions?
Yes, we are. Remember that a lot of the small NGOs do not have assets. So even when you think you're going through a very difficult phase, ideally, any corporation, and as I told you, I've been a few boards, is then you would go for a credit line, you go for some overdraft and run, but you need assets for that. And many small NGOs do not have assets. So you have to basically, and cash is king. So if you don't have cash, then you can't run the NGO at all. And therefore, the mergers are going to be considered more and more. And I see a lot of those mergers happening in the next 18 months, or at least strategic conversations around mergers happening, both from the northern NGOs and the southern NGOs. And for us as Amref, we are considering that as well. We are open to these conversations. We have had conversations in Italy about mergers with NGOs. I think we've been successful on one. We are discussing another. In Africa, we are looking to actually do a mapping across the continent to see which NGOs fit our ideology, our culture, and that we can start to discuss around mergers and partnerships as well. So it is a live conversation.
Yeah, and the donor community is trying, it seems, to figure out what their approach will be. Many people are calling for more flexibility from donors, and there are some that have stood up and said that, but it seems that a lot of the major donors are still trying to figure out what they'll do around COVID. What I'm hearing is they're extending existing programs, with the inability to know what to do, they extend what they have. Maybe they pause certain things, but what's your sense thinking about big donors? How are you seeing them respond at this point?
So what I've seen is maybe two different things. One is, three actually, one is donors coming and saying, don't touch our money, but we allow you to replan your work plan. So instead of doing this program in a year, we allow you to do it over 2 years. So that basically means that your overhead recovery is reduced and spread over 2 years. And therefore you have to worry about how do you then maintain the services which are jointly shared by programs, which are not directly charged into programs. So that's a major problem. The second thing we've seen is where they say, fine, we can allow you to repurpose some of the money into COVID responsive programming, where you say, okay, we have been working on TB work or maternal health work, so repurpose some of the money and train community health workers on COVID. So it's the same money, but they allow you to repurpose part of it to be responsive. The third one is where donors are coming up with totally new money to say, okay, we know you're going on with the programs, this is what we can do within that. But we also now have a new pocket where we can actually bring a concept and say, can we discuss how to support the government to respond to COVID-19? So those are the different approaches that we are seeing. And obviously the third one presents an opportunity for sustainability, because now this is new money and you are able to continue programming as you put a pause on the programs that you're not able to do. The final one is where donors are coming and saying, do we have new ways of doing the old things? And that's where technology is coming in. So if I had a way of training, we had a program to training 50,000 community health workers. We are like, how can we shift our money and maybe build the infrastructure to train them on mobile phones, devices? So those are the ways I'm seeing our donors responding.
Yeah, I've heard as well that because of this emergency situation and because of that donor focus on infrastructure, you're starting to see NGOs come together and say, we're willing to share data in ways that we haven't before. Maybe programs that use CHWs for one particular disease area or one particular intervention might be able to merge those programs together and provide a common platform so you can do contact tracing and surveillance and community engagement in a more holistic way. So maybe there are some things that will shift out of this pandemic that will change the very way that we cooperate and work together as an industry. But it's going to be a very disruptive period before we get to that, is my sense.
It's going to be very, but as we always say, never waste a crisis. So I think what we need to do is look at what are those things that emerge out of this crisis that we look back and say, we did it. And that's one of them. So in Kenya specifically, Amref is leading the community engagement pillar of this response. And we brought in all NGOs that deal with community engagement, all of them. And we are sitting together around the table and saying, how do we work better? How do we make sure that we have a holistic response? And there's not a single argument. We are moving forward. So never waste a crisis.
That's good to hear. Well, listen, thank you for taking time out of what I'm sure is an intense moment as you juggle the many hats you wear and leading especially a major international NGO on working on health issues. We are always indebted to you for your insights, and we'll be coming back to you many more times as this pandemic progresses for your take. So thank you, Githinji.
Thank you very much, Raj. Thank you. Great speaking to you.